Well, welcome everyone to the 27th Degree with Chris and Nancy. This is part of our medical series that we've been doing, and today we're really excited to have Dr. Sidney Olefson with us. Dr. Olefson's a gastroenterologist dealing with GI complaints, and we'd like to talk a little bit about a host of issues today. But why don't we start by, let's talk a little bit about you and tell us a little bit about your background.
Yeah. Well, first of all, thanks for having me on. This is fun to do. I grew up in New Jersey, and then I went to college and medical school in upstate New York, in Albany.
Mm-hmm.
I was lucky enough to get into a combined program where I was early accepted into med school, so I just went straight through to Albany Med. And then from there, once I graduated, I did my internal medicine residency at Brown in Providence, and then I did my GI fellowship after that at University of Connecticut in Hartford.
Great, good programs.
Thank you.
And now you're newly in Prima Care here in Fall River, Massachusetts.
Yeah, I'm very excited to be here.
Yeah.
Just started only a little over a month ago.
That's great.
So.
That's a great group you're with. So that's excellent. So let's talk a little bit about maybe some things that interest you in GI. I know that you have a particular interest in a couple areas, but maybe before we get into that, let's talk a little bit about, because COVID-19 is on everyone's mindset right now.
Yeah.
And there are some GI manifestations of COVID. Maybe we can talk a little bit about that since we've had this resurgence of COVID in the area recently. It'd be nice to talk a little bit about what maybe you see as a gastroenterologist in relation to COVID-19.
Absolutely. So, I think obviously initially most people were suffering from respiratory complaints, and that was the initial observation. But over time, particularly in some of the Wuhan hospitals, they were noticing a large percentage of patients had diarrhea. And that number ranges anywhere from 5% to up to 15% of people will have diarrhea. And they've actually looked at tested their stools for the virus, and they've found it in a good percentage, 40-50%. So that's a common finding. And then about a similar percentage, maybe 20%, have nausea and vomiting as well. We don't fully understand exactly why that is, but we're definitely seeing that. And there is, even more alarming is a lot of people may present with these GI complaints before they have respiratory complaints. And
Good to know.
Yeah, so that may be their first symptom.
At what point do you kind of get suspicious where it's like, if I have an upset stomach or nausea, diarrhea, and, I'm not thinking right away, COVID. Is there like a magic point in all of this where you're like, oh, something's just like kind of funky?
Well, obviously you have to, take into consideration the context, where are you staying at home, quarantining, are you out and about, and how bad are these new symptoms? Are these symptoms really, acute and quick in onset, or is this something that you've kind of, had irregular bowel habits previously, and this is just a little bit worse? I think for people who are normal and then suddenly become abnormal, obviously the first question is this an infection?
Right.
And obviously that's a question, but there are obviously other, probably more common infections responsible for, acute gastrointestinal symptoms.
So going a little bit past the COVID stuff, if I'm experiencing some gut problems, like when do I say, geez, I should really go see a specialist? Like, what are the most common things like you're treating? And if I'm out there and I'm not feeling good, what would you say to me is like, come on and see me?
Yeah, I mean, honestly, anytime you have new complaints, we see people for such a wide spectrum of symptoms and complaints that it's not unreasonable to at least reach out to your primary doctor to say, is this worth, considering seeing a specialist for? But, we see people for from upper GI complaints such as nausea, vomiting, loss of appetite, upset stomach, to lower GI complaints like diarrhea, constipation, bloating, bleeding is obviously a concerning thing. Abdominal pain absolutely should be looked at. So there's a variety of things. In general, it doesn't hurt to ask.
What's the most common thing that you're treating?
The most common thing that we treat probably is probably it's tough. Maybe acid reflux is something that we see quite commonly.
Yeah.
It affects anywhere from like 20 to 30% of the U.S. population, and now with COVID, there's been some press about the medicines used to treat it. Some medicines actually help COVID-19, such as famotidine or Pepcid, potentially, and some medicines have been shown potentially to be harmful, such as Prilosec or Nexium. But I caution viewers that it's not really a strong level of evidence to support that. So if you have symptoms of heartburn or regurgitation, that you should talk to your doctor about what's an appropriate way to treat that.
Maybe we can talk a little bit. This is an interesting topic to be too, because as a primary care doctor, I get a lot of patients who come in with acid reflux, who've had it chronically for years, and they've been on omeprazole, Prilosec, or Prevacid, or whatever it may be in that class of drug. And now they're concerned about those drugs because of what they've heard about, potential issues down the road, long-term side effects of the medications.
Right.
How are you dealing with that? How are you counseling patients in relation to that? Maybe you can talk a little bit about the problems that we're facing with that class of drug.
Yeah. It is a very well-studied drug with lots and lots of data behind it, and lots of decades of experience. But I would say that in general, there has been reports of side effects such as cardiovascular, poor outcomes, enteric infections like C. diff, vitamin malabsorption, bone malabsorption, and all these things are based on mostly observational data. And and the other problem is that the people who tend to take these medicines tend to be sicker at baseline. And so they tend to be a little bit higher risk for developing these problems. So in general, my approach, I think like a lot of my colleagues, is really to use the lowest effective dose to get the best response.
That's what I've basically been doing also. I mean, you have patients who are on these meds, they've been on them chronically, and then they stop them, and they really suffer quite a bit. Beyond the fact that, if they do have significant changes or damage to their esophagus, they're at risk for esophageal cancer, too. So there's a balance that you have to look at with all this stuff, right? But then there was all this stuff that came out about Zantac and impurities in Zantac, and patients for a while were calling me, and they felt they were left with nothing to use. So it required a lot of counseling.
Unfortunately, that was a true impurity that was in a batch of Zantac or ranitidine that has since been withdrawn from the market, and the FDA has already commented on that this past spring. But we have a lot of that should not deter people from treating themselves, from living and suffering from these symptoms. The other thing that I do see a lot of is people who have a real strong, good reason to be on these meds, such as a condition called Barrett's esophagus, which is a precancerous condition, and they'll ask me if they can come off of it, and really, in my opinion, the evidence really supports staying on that to help mitigate their risk of cancer in the future.
Right.
Getting back to acid reflux, I mean, just speaking from myself and my friends and what I see people do, it's just like we're staying away from meatballs and spaghetti and the sauce and everything else. So there's foods that I would stay away from. Are there any magic foods that are great for your gut that that I'm like, oh, I got to get me some onions and garlic or something, and yogurts or whatever.
Well,
what foods would you recommend for general GI
gut health?
General gut health, I mean, in general, the whole field of dietary research is pretty, it is hot right now, and there's a lot of research into that, and patients are extremely motivated to try different things. Unfortunately, the data to support one particular food or, group of foods is not really strong. In general, we, almost all of my patients I tend to recommend fiber for. We know that the benefits of fiber for for lower gut health particularly, and regularizing your bowel movements and minimizing gas production, et cetera, is really there. And there's also some benefit for, glucose metabolism and maintaining sugar levels. So in general, that's pretty strongly recommended. We do have, some evidence for, in terms of thinking about cancer prevention, like colon cancer. We may not know exactly what's good, but we know what's bad. So we know that red meats and processed foods tend to increase the people's cancer risks overall. So, we caution people against that. We do talk about things like, alcohol, as it's kind of a shifting pendulum on whether or not it's healthy. There is some evidence to say maybe there is some cardiac protection with a little bit of alcohol, but too much kind of tips you over and puts you at higher risk of liver problems.
I feel kind of good that we eat turkey for Thanksgiving now instead of a great big hamburger in the middle of the table. So with all the diets that people are trying now, the keto diets or intermittent fasting, is there one that you kind of like to see people on, or is it just kind of that general, you're staying away from the processed stuff, you're not eating a lot of those like refined sugars, so like any of these diets are kind of...
I mean, I agree. I think that, there's so much out there. It's easy to get very lost and confused, particularly even as a provider. What's real, what isn't. You mentioned intermittent fasting. There's animal models that say that starving rats for a period of time, they live longer.
Right.
Whether or not that applies to humans, we don't know. But a lot of people are starting to do that, and we'll see with time if there's information that shows that that's beneficial. We do know that people who tend to live around Italy and the Mediterranean, they tend to eat a specific diet, and data supports that maybe that's beneficial. Maybe increased nuts and beans and unprocessed foods and wine, maybe beneficial to people's health overall.
The blue zones,
The blue zones.
Right. It's really interesting where people live greater than 100 very regularly.
Right.
It's fascinating.
Right.
And their activity level is higher too.
Well, the Mediterranean diet's a big part of it, but the other interesting thing with that, and this is getting a little bit away from kind of the whole GI discussion, but when that's been studied, it's very clear that people in that environment, they maintain their importance in their family unit. So, the grandmother, the great-grandmother, the great-grandfather, they often live together with, younger children, and they're taking care of them, and they have a role. So it's not as if they retire and then do nothing. They never really quit. And I think that's, our society is very different. We retire and, really, I see this in patients all the time. Unless they have something that they're doing regularly, you really see their health decline. And often their cognitive status declines too. I think the cognitive issues are really key. I see this often over, the last 20-something years of practice. I've seen people who retire and have a plan and they maintain decent health. They're exercising, they get up with something every day to look forward to. And then I see people who, retire and don't really have anything to do, and they don't have connections with others that are strong. And I see those people decline quicker. And I think that's a big part of this whole blue zone thing.
We should do a little podcast on that retirement health and kind of do a little focus
it's a
on
great
that. That
topic.
would be really interesting.
Yeah. So let me ask you another question. I know that you have a particular topic of interest in hemorrhoids, and that's a real pain in the butt topic, really. But as a primary care doctor, I have a lot of patients who come in and they ask me about hemorrhoids, and really, I'm interested in this because there really hasn't been anything to offer them, right?
I know.
I give them some topical medications.
Yeah.
If it's really bad, I used to send them here and there to surgery, but that was such a brutal surgery.
Yeah.
Patients really had difficulty recovering from it, and there wasn't really much else to do. So tell me what you can offer patients, because I think there's a lot of patients or people out here who probably are interested in this.
Can I back up a little bit from that question too, and just like what will cause hemorrhoids? Like what makes it that risk for
we can talk about the
So in general, hemorrhoids hemorrhoids are, everyone has them. A newborn baby has hemorrhoids.
Okay.
But not everyone develops symptoms. And, basically they're, this cushion of tissue in the bottom of the rectum that is covered with a layer of mucosa that, over time can get enlarged and can become irritated. And symptoms, not everyone may recognize what symptoms may be of hemorrhoids. So bleeding, itching, seepage, and what's called prolapse, when they have a sensation of the hemorrhoid kind of coming out. Pain is kind of a thing that a lot of people attribute to hemorrhoids, but not necessarily. Internal hemorrhoids, which are just north of what's called the dentate line, which is the area of sensation, they cause no painful sensation. It's the external hemorrhoids, which occasionally can become thrombosed, can cause pain. Now, we know that most people, we don't really have a lot of good data on hemorrhoids in general and symptoms of it, but we know that probably the one study from 1989 showed like maybe 20-30% of people ever had symptoms of hemorrhoids, and that number is probably higher, to be honest. But yeah, so there are topical things that are available over the counter. Some people find that they help, things like hydrocortisone, anisole, Tux pads, witch hazel, stuff like that may help. But a lot of people, for some people, they continue to have repeated symptoms despite these efforts. So one thing that I do and that has become more popular in time is rubber band ligation.
Okay.
And this is an in-office based treatment, basically where you place a rubber band around the hemorrhoid, and that tightens up the area and basically causes, intentionally causes an ulcer and scar formation, so that the tissue between the hemorrhoid and the underlying muscle layer becomes more sealed together. We find, myself and some of my colleagues that 95+% of people get rid of symptoms from it.
So you're putting the rubber band around and I guess cutting off the blood supply to the tissue?
Right
basically?
right around the tissue. Yep. And it's done in the office. It's done while the patient.
Should we stress that so people aren't DIYing this at home?
Yeah, don't run out to Home Depot and get some rubber bands.
Just put a rubber band. But there's like a certain skill to this.
Absolutely. Yeah. Absolutely.
That's a good point. Thank you for bringing that up, Nancy, because I don't want to be responsible for any do-it-yourself nightmares.
No. But yeah, I mean, it's an office procedure. They come in and it takes about 90 seconds, 2 minutes to place. They're awake. And the reason they're awake is because of that line. I want to make sure that I'm placing it. Again, another reason not to try this with Home Depot.
Sure.
Stuff you want to place it above that line so there is no pain at all.
Okay.
That's the goal. It's a painless procedure.
Oh, that's great.
Yeah.
So they're not feeling anything of concern.
Yeah.
That's good.
Yeah.
And are there any what are the risks of this type of procedure?
The main risks are pain, what we do in our office is we monitor them for about 15 to 20 minutes after the procedure, because the pain is immediate. It's generally not delayed, and we see that in probably less than 1 in 100 people who get it. Rarely is there anything more severe than that, such as bleeding, etc. If that develops, it's generally temporary and resolves on its own. But those are pretty much. This is I'm comparing this to a hospitalization for a hemorrhoidectomy. Which definitely has efficacy to it, but people need to stay in the hospital for it. So totally different scenario.
And they have normal bowel function right after this procedure is done.
Yeah. Oh yeah. Normal. There's no change to lifestyle except for the usual recommendations that I make for patients, like we talked about earlier, about increasing fiber intake, increasing water intake, taking a walk around the block.
Yep.
All just good for gut health.
Yeah, and then the rubber bands just fall off after a while. I'm assuming as the tissue kind of
2 to 3 days
dries
they're
up.
gone. Nothing to worry about. Yeah.
I was thinking you had to have a repeat visit for
No.
a rubber bandectomy or something.
No.
Oh, that's great.
good.
So that's a really nice thing to know because I get this question all the time, and,
Yeah.
and there really hadn't been anything to offer patients in
Yeah.
this area other than surgery,
Yeah.
and, which I really would try to steer people away from if I could, unless they
Yeah.
were really symptomatic.
Yeah.
So,
Yeah. I mean, they're not every, like about 95, 99% of patients will respond to this, but
Yeah.
there is a small percentage that may not, and they may need surgery. But
Yeah.
in general, we try to avoid that.
Right. Okay.
Is this area known for increased GI concerns with like GI health? Like, are we seeing more? I'm going to guess that it's probably a yes because of our diets. in
Well,
this area.
yeah, I mean, you can probably
yeah.
speak more to this, but yeah. So.
Yeah, I mean, the caveat being I'm new to the area, but in speaking with my experienced colleagues that things like obesity is common to this area, and as a result, things like fatty liver, which is now becoming the most common liver
Right.
disease in the United
Right.
States, and will probably become the number one reason for liver transplant soon. Now that
Wow.
hepatitis C is basically totally curable.
Correct.
So that's a common thing. The other thing that's really common in this area is an infection in the stomach called H. pylori, Helicobacter
Yeah.
pylori, which is generally acquired in childhood and the most common cause of ulcers in the stomach, and the most common cause of stomach cancer, which is still fairly rare in general in the U.S., but
Yep.
in this segment of the U.S. is apparently fairly
Yeah,
high.
we have a fairly high incidence of gastric cancers and esophageal cancers,
Yeah.
definitely in this area. And there may be some genetic
Yeah,
issues there,
Yeah.
related to the Portuguese population.
Yeah.
So,
Can I go back to the H. pylori?
and dietary issues
And-
too.
So, like, can you talk a little bit more about that? Like, how do I know if I'm at risk to having this H. pylori? And are you screening me if you're my primary doc? Like,
Yeah.
how?
it's a good question. So
Yeah.
it's not something that we routinely screen asymptomatic people for. So, but people who have almost any variety of what we call dyspeptic complaints, upset stomach, abdominal pain, nausea, vomiting, we will often screen them up front for it. And we can test for H. pylori in a variety of ways, one of which is through a stool sample, another of which is through a breath test, and another way is through direct biopsy of the stomach lining and to look under the microscope for evidence of it.
And then if I have it, what do I do?
So if you have it, then it's pretty easy to treat in general with generally a 14-day course of antibiotics will get rid of it.
I love the H. pylori story though of how it was created.
Oh my God!
It's like one of the best
Wait,
stories
I don't
in
know
medicine.
This story.
This is one of the
Yeah,
best
this is-
stories in medicine. I mean, you can probably I speak to it more, but I don't remember the names of the physicians involved.
I'm blanking on it as well.
But so essentially, there were, I believe, two physicians
Yeah.
who believed that H. pylori was the cause of ulcers, and they believed there was this association between a bacterial infection and peptic ulcer disease, and they really got laughed out of the medical community almost. So finally, they decided, we're going to prove this, and they used themselves as guinea pigs, and they took some nasty-looking stuff that had H. pylori in it, and they drank it, and then they looked down in their stomachs with scopes, and they had the infection and they had ulcers, and they ultimately won the Nobel Prize. And they were completely vindicated. But it's one of these great stories where here's someone who brings something up that just seems so off the wall, and they really believed it, and they had a passion for it, and they studied it, and they pursued it, and they were right.
Yeah.
It's a great story.
Yeah.
It really is.
don't
Except
know.
that drinking the
Yeah.
gunky stuff.
I don't know
that's
if I
not-
drink a whole cup of bacteria to get a
Yeah,
exactly.
yeah.
but
Prove my
Just a
point.
great story.
It's an
though.
amazing story.
Yeah, and I mean, it is one of the main reasons that we see for peptic ulcer disease.
Yeah.
It may be, is it number one?
Yeah. Oh, that and the other common thing is non-steroidals.
Non-steroidals. Yeah, right.
But yeah.
So it's just fascinating.
So you talked about having scopes in your bellies and everything. I guess we should talk about colonoscopies.
Oh yeah, we probably should. Yeah, let's talk about that. Because so many people are afraid of colonoscopies.
Yeah.
They're afraid of the prep. They're afraid of the procedure. They're
Yeah.
embarrassed. but it's really life-saving.
Well, plus it's like, oh, I turned 50, and there's some psychological stuff that comes with that, and like, oh, good, now I go get a scope.
Well, but people
You know?
are like, oh, the doctor's going to be doing this and looking at that part of my body. And I mean, as a gastroenterologist, how many of these do you do a week? I mean, you're doing a lot. I mean, it's
50
like,
plus,
exactly.
yeah.
So
Yeah.
it's an important
Yeah.
thing to keep in mind.
Yeah, it's
I have to just give a little bit of a plug for Prima Care too.
Yeah.
That new endoscopy suite.
Yeah.
It's so nice.
it's so nice.
And
it's
the-
new to me, and it's
yeah,
beautiful.
yeah.
It's
And
really
the staff
awesome.
there, I had an opportunity to work with the staff there. They are so sweet. When we did the patient experience surveys there,
Yeah.
oh my God, they got like great marks. But they're really, really a sweet staff, and the place is phenomenal.
Really nice. Yeah. Yeah. I mean, we've come a long way. I think, patients tend to rely in general on like what their friends tell them. And,
Yeah.
maybe their friend had a colonoscopy and they woke up in the middle of it 25 years ago.
Right.
But now we do all of our, procedures with propofol, and it's quick on, quick off, and
Yeah.
that's not a problem. And our scopes are, have improved dramatically in the ability to detect polyps, which are the precancerous, precursor lesion to colon cancer. And our techniques for removal have also improved pretty dramatically. So, yeah, I mean, it's, I don't know if you're familiar with, Will Smith. He did he photo documented.
Did he?
Yes,
Really? I didn't know that he did that.
Yeah,
That's great.
Yeah, that's
Yeah.
great.
Yeah, and I think Jimmy Kimmel did as well. So to try to, dispel all this myth about, that it's, a bad thing or uncomfortable or whatever.
I've had a couple because I have a family history of colon cancer. So I've had like 2 or 3 now at this point. I started having when I was 40.
Yeah.
But the first one, or maybe the first 2 I had, it was like Demerol and Versed.
Yeah.
And I remember, I mean, I was awake and it was a little, I was aware. Maybe it wasn't as comfortable as I would like.
Yeah.
But the last one, maybe the last 2, but certainly the last one, it was propofol. And I remember the anesthesiologist was there. And it's important to understand also for our watchers that there's an anesthesiologist there. So, if you've heard about propofol and Michael Jackson, don't worry. You have an anesthesiologist there, okay? And he said, count back to 10. And I remember getting to 8 and being completely out. And the next thing I woke up and it was done.
Yeah.
And you have no sensation and no memory of this being done.
It is, it's almost the whole shift to propofol is largely, I think, patient driven because of the ease of experience, but it's unbelievable.
Yeah.
So you had mentioned polyps. Can you talk a little bit about polyps too?
Yeah.
Is that like a word you never want to hear, like when you're done with the colonoscopy, or is that okay?
No. About, depending on what age you're cross-cutting, I mean, 40-50% of the population has polyps. Only 5% of the overall population gets cancer itself. So not all polyps turn into cancer, but we have enough scientific basis to know that the polyp is the initial lesion that will eventually become a cancer, and it's it's this story almost like what you talked about H. pylori and the success story of understanding this. Our understanding of colon cancer has become just the paradigm of cancer prevention because, in contrast with breast cancer screening, where, we're doing these mammograms, we can't do it involves 9 other steps down the road to diagnose and prevent that. Or, pap smears where we're staining and eventually, ablating, et cetera. Colon cancer screening is which has really become almost universal population based since the early 2000s, it's a one-stop shop really. You go in, you drink this prep, you're dreaming, and you're having a nice nap. You're not aware of anything, and really, these fiber optic scopes with their with their enhanced visualization are really, we're finding these tiny little polyps and removing them. Not all of them can turn into cancer, but we do know that there are some, not all polyps are the same, and there are some polyps which have higher risk potential than others. And we know that people who tend to harbor those higher risk polyps are a little bit higher risk. So not everyone gets a 10-year bill clean of health after their
Right.
colonoscopy. And so that's really the only major concern. But
And I guess too, when you start feeling bad or feeling like something's off, I'm gonna guess that you're probably looking at a later stage in what you would have wanted if you had just gone in for a screening.
yeah,
You
yeah.
know?
I mean, we always make a distinction between a screen, which is someone who has no symptoms, versus a diagnostic test where someone is having symptoms which could be suggestive of a colon cancer.
Right.
And obviously, I should mention things like rectal bleeding, weight loss, severe constipation. Those sorts of things should, obviously prompt a quick notification of your doctor. But
Because you could be feeling great and then go in for a screening
Correct.
and have something picked up that could
Correct.
be like literally life saving.
Correct.
Yeah.
And I think another kind of changing aspect to this is, I don't know if you're from the USPSTF. They just commented that they're probably going to lower the screening age.
Mm-hmm. I was aware of that.
Pretty recently from 50 to 45. Not yet official, but that represents kind of an acknowledgement that we've done such a good job in the 50 plus in lowering incidence and lowering mortality, that we're now seeing a rise under 50 in the underscreened.
Yep.
So the most recent cultural example, Chad Boseman from Black Panther, 38 years old.
Yeah, that's sad.
We don't see that commonly, and
No.
that's but it is it's a horrible thing, and we want to be able to figure out ways to find those people and screen them earlier.
Right. I mean, it's amazing that now you hardly see anyone with advanced colon cancer who has been screened. I mean, they're picked up. I mean, the patients I have here and there who have colon cancer, they just kept refusing year after year any colorectal cancer screening. And it's sad when that occurs because it's so preventable.
Yeah, it really is.
I mean, you could really almost prevent almost every colon cancer
Yep.
if you do colonoscopy. And it's a
Absolutely.
really, really benign procedure. You don't really see complications that much either. I mean, there are some described, and patients are nervous about that. But
Yeah.
I can't remember the last time a patient had a major complication from a colonoscopy.
Yeah. I mean, I can say that in general, with the huge volume that we're doing, because we're basically screening the population, we see it, pretty infrequently. The most common, more recently, were things like bloating and discomfort afterwards, because in order to see the colon, we have to distend it with air. But now, we're in addition to the propofol for comfort, we're using CO2.
Okay.
CO2 instead of oxygen is still distending the colon, but it's being absorbed, and it's not causing that lingering discomfort.
Well, that's
that people
interesting.
have
I didn't know that
afterwards.
was being used now.
Oh yeah, so we used to use like rectal tubes afterwards to to help get
Right.
past that gas. We don't need to use it anymore. Patients, they wake up, they feel great, so that's a really nice modification to what we do.
That's great.
So the other thing I wanted to ask you, and I'm totally switching gears
Yeah.
here, but the gluten free, like when you go out to eat now,
Yeah.
it seems like everyone has a gluten free menu.
Yeah.
It seems like celiac disease is, I don't know if I want to say it's more prevalent,
Yeah.
but it certainly seems like it is.
Yeah,
So can
yeah.
you talk a little bit about that?
Well, so we are, in general, in the past 20, 30 years, we have seen a rise in the incidence of celiac disease, now probably 1% of the population. So that's definitely true. But happening at the same time is this whole gluten-free phenomenon.
Right.
And
what does it mean to be gluten free, just for someone who doesn't, like, what are those restrictions?
Avoiding wheats, rye, or barley in your diet, which contain this protein called gluten, has been attributed to a lot of general problems, and there's been a lot of popular press about the badness of gluten. Now, celiac disease is a completely so there's really two different ways to look at it. One is celiac disease, which is really your body developing in almost like an autoimmune reaction against the gluten towards your gut.
Yeah.
And it primarily affects the small intestine. the duodenum. And so really, I'll see people, they say, oh, I looked up symptoms online and I have celiac disease. That's not how you diagnose celiac. The true way really is with biopsies of the small intestine and looking for that characteristic inflammation changes. But a lot of people don't have that. They don't have any of the blood tests. The serology is positive for it. But they do find that they seem to do better when they're come off of gluten.
Yeah.
Their bloating improves, their pain improves, their diarrhea improves, but they don't have any testing positive for it. So, what do we do? It's kind of it's almost like an in between. And I never think I never outright discourage people from being on a gluten-free diet. I do caution patients because complete gluten abstinence has a tendency to be an imbalanced diet, and you have a tendency to have excess carbs or excess fat in your diet at the expense of avoiding gluten. So it's worth the trial if but I generally recommend that people do it with let their healthcare provider know. So I'm going to be trying this, and
So I want to just move on to another thing, if you don't mind.
Not at all.
If there's anything else you want to say about gluten-free diets and gluten. So probiotics, this is something that comes up all the time with my patients. They're very interested in probiotics.
Yes.
And I have some patients who say they really feel better with a good probiotic. They feel that their bowel habits are more normal, that maybe they have less inflammatory type symptoms, joint pain, things such as that. What do you think about that?
Yeah, well, so in general,
Doctor, could you start with just explaining what a probiotic is?
Sure, yeah. So, initially, the whole concept of the probiotic came from the idea that there is this population of bacteria living in your gut, and not everyone, it's like a fingerprint. Everyone has a different, composition of all these organisms living in their gut, and that has led to this explosion on the market of these, capsules that have live colonies of bacteria that we think, may add on or replace our living microbiome. And since we're starting to see that there is correlation between certain symptoms and diseases and the composition of your gut, so maybe manipulating that microbiome would be helpful. And there's an intense interest in it, like I'm seeing, but there's just not really great literature out there. The problem is that a lot of these probiotics which are out there are not necessarily FDA regulated, and there's a lot of variety in both composition, what sorts of bacterial strains are in it and how much, and what combination of it. Our society has come out and been sort of hasn't really committed straightforward to like the use of probiotics for a lot of GI disorders. There is some small base studies that say that maybe in high risk individuals, certain probiotics would be helpful for C. diff, which is the most common gut infection, but other things like irritable bowel syndrome that almost everyone has been taking probiotic. They actually caution against it and only use in clinical trial. That said, I think that the risks are almost negligent in general. We don't see people admitted to the hospital with bacteremia from probiotics. When I tell patients, I say, certain products have more, experience, things like, Culturelle or Align or Floristore. And they're a little bit more expensive. They're not prescription based, but they have colony counts in like the billions. And that's always what people should be looking for. There is one condition, a rare condition, that people who have pouchitis, which is like people who have had surgery for their ulcerative colitis, they've had their colons removed. For whatever reason, their microbiome there is, is disordered, and there is a probiotic that is really shown in trial after trial to be effective. So they actually, the society comes down and recommends for that. But outside of that, there's really not much evidence, unfortunately.
Yeah. It's interesting. It might be one of these things down the road. There'll be more evidence and more studies that are done. It's anecdotal, but there are some patients who
They feel good.
feel good with it, and maybe
Yeah.
it's placebo effect, maybe it's not. But
Yeah,
I start to wonder because
absolutely.
you do see people who feel better, and there's so much antibiotic use in our society.
Absolutely.
It's not hard to understand how our bacterial flora could be
Oh yeah.
disturbed, and not only that, but the antibiotics it's in our food sources
Yep.
too. So
Yep.
yeah.
I mean, look at cows in our dairy industry. They
Yeah.
give them antibiotics
I
to
know
increase their weight and all that
Right.
stuff, and
it's
it's everywhere.
it is, and even if we're not taking antibiotics on our own, we could be affected.
We could be
certainly.
exposed to it. Yeah.
Yeah, absolutely.
Is there a big deal in your mind with when we talk about GI health, like the organic foods versus the non-organic?
Yeah. For the environmental impact of that, I think that totally makes a difference. Organic, in terms of health, I'm not aware of a lot of data saying it's healthier necessarily. They're certainly more expensive.
Yeah.
And there's certainly, if certain types of foods with thinner skins, tomatoes and some of the berries and stuff, it maybe some of the pesticides that they use are not as easily washed off. But other foods, maybe it's not necessary, like bananas with the thicker peel, or oranges, or watermelons, whatever. But
It's kind of a good way of looking at it. I never.
yeah, that's.
Yeah.
I mean, I don't know how you counsel your patients.
I think about it the same way.
Yeah.
I mean, I do become concerned about the, how we've tainted our food supply over
Yeah,
the years.
absolutely.
But I don't think you need to buy everything organic because
No.
it does become quite expensive. And for
Absolutely.
some people, it's not really feasible to
No.
do so. But like you say, there are certain products, and this is easy to research online. There are certain products where the skin is thin, or they you can't wash off the pesticides of the products that you want to get rid of. So
Exactly.
there's probably some value to it.
Probably is.
And
yeah.
I personally I try to go with that if
yeah.
I can.
Yeah.
But
So it seems like all through our conversation today that there's been a big element with diets and how that affects everything else. And sometimes it seems like we as a society look for this magic bullet,
Right.
and it's just really going back to the balance that you create in your own life
Yeah.
between, even what you were talking about, Chris, with the blue zones
Mm-hmm.
and the diet and activity and, doing things that when you think about it are pretty common sense.
Sure.
As we wrap up, do you want to say anything else to our listeners as far as GI health is concerned, or GI wellness?
some
Or
take-home points.
Yeah.
maybe?
Well, I think one thing we actually haven't touched, which I think is a big theme, is, at the start of this pandemic, things were, crazy, and we began to cancel, everything, including our elective procedures, etc.
Right.
Yeah.
So one concern that our specialty has had, and I think probably others have had, is that people were initially afraid to seek medical care.
Right.
They didn't want to go to the hospitals, and they didn't want to come in and have their screenings done, etc. But obviously now, things have become a lot safer, and we were just talking about how we're seeing lower death rate anecdotally from the virus. So I definitely would encourage people. Our concern is that there might be an uptick in like colon cancer,
right.
Because
Right.
people
That's a
just aren't
great
coming
point.
in.
Yeah.
Yeah.
So definitely, going back to your question earlier, what sorts of symptoms should I talk to the doctor for? I would have a low threshold to ask these questions. Is this, bowel habit change normal? Should I see a specialist about it?
Yeah.
Because, people really shouldn't be afraid.
Right.
The same thing goes for non-GI issues. Heart attacks and strokes were
Sure.
down in April. but we know that people are still having them at home.
Yeah, it's very safe to come into the office now.
Yeah.
I mean, everyone is screened. They're not allowed in if they have responses to the questions that we ask that are put them in a high risk category. I think it's honestly much safer than going to the supermarket or
I
being in
agree.
any
Yeah.
type of
Yeah.
situation like that. And like you've mentioned, I've seen, unfortunately, a number of patients who have avoided coming into their physician because of these concerns. And when they do come in, their blood pressure is, 190, and they have headaches, and
Exactly.
they're an impending stroke.
Exactly.
So you have to take care of yourself, and it's really important for everyone to understand it's safe to come in.
Yeah,
It really is.
absolutely. Yeah. Yeah.
Now, Dr. Olefson,
Yeah.
you're taking new patients right now.
I am.
Correct.
Yeah, I am taking new patients. And anyone interested that can contact our office, the Prima Care office.
Yeah.
67. Oh, get the number.
Well, while you're looking that up,
This
the
is a
other,
test.
yeah, the other thing to keep in mind is you can call your primary too, and,
Yeah.
and ask to be referred to Dr. Olefson, and,
Yeah.
and they can do that also. And
There it is. It's 679-6611, area code 508.
Perfect.
Still don't
Thank
even
you.
know my own number. Yeah, there you go.
that's okay. Everything's on speed dial, so it's
Yeah.
hard to remember. So, very good. Well, this has been great.
Thank you.
Really, really appreciate you coming down here and talking to us about, the variety of GI topics, all really important. I think it was really, we all learned a lot. So thank you so much. And I want to remind everyone who's listening that we're going to continue our medical series, and in 2 weeks, we'll have a cardiology session. So we'll have Dr. Pont in for that, and he's really great. And he's going to talk about some really new, novel things that are being done in the field of cardiology. But Dr. Olefson, thank you very much. We appreciate you being here. This was really great.
Thank you. Thank you for having me. This was really great.
Thank
Appreciate
you.
it. Yeah.